population remains indigenous, and traditional indigenous health beliefs are still widespread in modern society today. Politically, it's a representative democratic republic. It's not too different from America. It's divided into 25 regions. Each region has an elected government. There's a president who has 5-year term, and there's a Congress as well. There's compulsory voting also. Peru actually has a high human development index, which is a statistic made up of life expectancy, education, and per capita income indicators, which indicates that the healthcare system could be doing pretty well. However, there's a lot of disparities that we'll address. The major exports are a lot of raw materials: copper, fish, lead, coffee, sugar, and cotton. So I actually wanted to start off just with a little exercise. You've got a map of Peru here with some major cities and major airports. So this is like a little game that I made where you've landed in one of these places in Lima, Cusco, or Manu. Manu is when you want to tour the rainforest, that's where you go. Cusco when you want to get more of a sense of the traditional culture and visit Machu Picchu, which is a world wonder. And Lima, which is the capital city, and you can go visit the coast and go to islands there. But we're here to get healthcare, not to tour, and so I want to have this experiment where each of you starts off with 5 units, and each unit is a healthcare center or a traveling point. So it costs 1 unit to travel, 1 unit to establish a healthcare center. How would you guys get healthcare to the majority of the population in Peru? Where would you land, and where would you go from there? Anyone want to start?
I guess Lima.
Okay.
First time in Lima.
Do that. So you land in the capital city. Oh. You live in the capital city. That's the highest. Maybe I should stop using the laser. The highest proportion of the population lives there. Do you establish a healthcare center, or do you move on? Okay. So where do you go from there? There's no right or wrong answer.
I guess move on.
Okay.
Just thinking that they probably already have some healthcare centers since it's urban.
Okay, so Lima is over here. Where do you go from here?
The geography is pretty difficult because it's all mountains
Mhm.
by side, so it's weird. You have to fly.
Well, these are the airports. You can't fly. But we'll say you can spend a traveling point to get there.
I think I would go to Cusco because it's like in the
Okay.
it's like close to Lima, but it's like kind of in the mountains, so it's a different region.
Yeah.
And then I also think the north like is not covered at all at the moment. So with this kind of photo,
Your left Lima is more like a flat geography.
Well, this line is the mountains here. It spans the length of Peru. Okay, so that's so you've traveled. That's 1 unit to Cusco. Established healthcare there, right? 2 units, and then a 3rd unit to get to Tarapoto. Right. So 2 more units. Kingdom, did you wanna?
Yeah, no, I just wanted to know. So does the size of the circle signify the population size?
It does, yeah.
Okay, so definitely Tarapoto,
Mm-hmm.
yeah. And also going here to Diego. Where is it?
Going to Diego. Oh, going up. Okay.
Near Colombia.
Okay, so
That's the Amazon region, so
Yes.
1, 2, 3, 4.
medical center or
That's 5 points, but you have no more points to establish a healthcare system here.
I just got there, but I can't do anything.
You can't do anything.
Okay, then I'll return.
Okay.
And then keep my 1 point. And so could I use more in one place? Because I mean,
You can,
I mean
yes.
the population of Tarapoto is similar to Lima,
It's quite big.
right? So I mean, I'll rather invest there as well.
Okay.
Overinvest.
So that was awesome. I actually think you guys did really well. This is the train system in Peru, which is the reason it costs a traveling point to get everywhere. There's nothing up here, and this really is only in very limited regions that kind of follow where tourism goes. So here is a full map. Vania was pointing out the geography. There are 3 really defined environments in Peru. You've got the coast right along here, which has the majority of cities. You've got the mountains in the Andes, and then you've got the rainforest. And all of them require different transportation. All of them have different healthcare needs. And I just wanted to get you guys kind of thinking about the struggles that people have with limited resources when they're trying to get healthcare to Peru. So, in terms of population demographics, there's 31.2 million people in Peru. 26 to 40% live in poverty, depending on your definition of poverty. The language is 84% Spanish, 13% Quechua, and 3% other. The average life expectancy is 74.5 years. This goes down to 62 years in rural areas, which is a huge, huge difference. The average lifespan, though, it is higher than the global average, which is 71.5. However, the observed life expectancy this year was actually higher than the expectancy that they thought would happen. Males live for almost 78 years and females live for 81.1 years. We're going to talk about urban-rural differences a lot. There's three major disparities: urban-rural, rich and poor, and indigenous and non-indigenous people. And in general, the poor, the indigenous, live in rural areas, and it's the richer, non-indigenous people who live in urban areas. So the rural population, 22% of the overall population, highest poverty rate in Peru. And looking at the region specifically, you can see each one of them has a different main disease, which means different healthcare needs, different training required, different infrastructure, things like that. The Andes Highlands, which is this middle section, is 36% of the overall population. It's rural, isolated communities that are really hard to access due to lack of mountainous transportation infrastructure. And they actually have a 50% poverty rate. Most of them work in agriculture and mining. And as we learned from Epi, this is associated with chronic respiratory illness, exacerbated by rough winters, by having fires in the home to keep warm. 40% of the rural population, main disease, chronic respiratory. The Amazon Basin, which is the rainforest, they have 12% of the population overall, and then 34% of the rural population, and they have infectious tropical diseases as their main burden. But they also do have respiratory issues during winter. Finally, the coast, 60% of the population, the majority, but not by a lot. 24% of the rural population, they have a much higher prevalence of chronic disease, which is kind of what we see in developing areas in general. They have a double burden. They have the burden of infectious disease and of NCDs such as depression, cardiac issues, cancer, for example, things like that. And there still is a prevalence across the country of HIV/AIDS and TB comorbidity. The rural community has overall less access to healthcare. They have lower incomes, they have less government services, less electricity, less education. They have worse environments, and they have worse health. The richest 20% of the population consumes 4 to 5 times more health goods and services than the poorest 20%. And Lima in particular, where Linda decided to land and assumed that there was healthcare, and she was right, it has 23% of the entire country's hospitals. So more about the demographics. I have the literacy rate, clean drinking water, and sanitation, and really the important thing to notice is just the disparities between urban and rural. Urban rates are pretty good. I want to point out sanitation specifically, where only less than 40% of people in rural areas have access to appropriate sanitation infrastructure. The fertility rate is 2.4 kids per woman, and the median age is 25 to 54 years old. So it's a pretty young, middle-aged population. A lot of people don't live till old age at this point, like we see in mainly developing countries. But this is increasing, and we can expect a boom of elderly in the next 50 years, which the healthcare system has to be prepared for. And I don't think they're really there yet. And there is a decrease in young people here, which we'll talk about in a bit, the reason why. It's due to forced sterilization by the government, and this is going to play into healthcare in a huge way. So comparing OECD statistics from Peru and Israel, in 1990, Peru had the 4th highest infant mortality in the world. It was 75 out of 1,000. So it has decreased very steadily and very significantly since then, thanks to improved health services in rural areas and control of respiratory infections and diarrhea mainly. There's also been a lot of campaigns promoting breastfeeding, promoting vaccinations, promoting women's education, and better attention during labor and health centers. So almost every woman now in Peru has at least one prenatal care visit, which is huge. In the Andean region, which was the mountains, there's still a mortality of 52 infants per 1,000, and most of them are being killed from freezing temperatures and smoke inhalation. And in indigenous communities, infant mortality is 3 to 4 times higher than in the average population. So it's decreasing, but the reason we see this huge decrease is a decrease in urban areas, and it's really not the same in other areas in Peru. Maternal mortality, as you see, is also quite high. Hospital beds, physicians is lower than it should be, but that's kind of a problem all around the world, as we've seen with the global shortage. Hospital beds is not too bad, except that preventative care isn't very good in Peru. So actually they end up needing more hospital beds than the average recommended. But it is, kind of similar to Israel, 2.4 to 3. And then finally, healthcare expenditure is 5.5% of the GDP, which is not a ton, but it is higher than the Peruvian government spends on a lot of things. It's higher than military GDP, for example. So it is pretty significant. But overall, these statistics look high, but increased access to medical care and falling poverty rates have led to strong improvements in public health, and really significant drops in under 5 mortality, in malnutrition, and in maternal mortality. And by almost every single measure, the Peruvian population is healthier and getting higher quality care than they were 15 years ago. So we're looking at the burden of disease. The top 10 causes of disease, we've got lower respiratory infections, which we mentioned is especially prevalent in the Andean region. Heart disease, stroke, cirrhosis, kidney disease, stomach cancer, diabetes, COPD, congenital abnormality. Most of these are NCDs, which is typical in developing and developed countries. However, so the burden is quite similar to Israel, similar to America. NCDs are the main cause of mortality, but for disability-adjusted life years, the DALY, which is over here, the DALY, which is over here, maternal, neonatal, and nutritional issues are actually number 4, so they're still quite high. And infectious disease in Peru, especially waterborne disease brought over by Spanish colonists like Hebe, dengue, malaria, yellow fever, they're all still really big. If you ever go there, you have to get vaccinations before you go. And the top 10 causes of death for children, congenital anomalies, prematurity, injuries, pneumonia, birth asphyxia, neonatal sepsis, diarrhea, and HIV/AIDS. So with children, you can really see that a lot of them are still communicable disease and not non-communicable. And I thought this was just a really cool chart to kind of see how the leading cause of DALYs and mortality is changing over the years. So this is a percent change between 2005 and 2015. If it's this way, it's decreasing, and this way, it's increasing. And communicable disease, decreasing. Injuries, decreasing with better infrastructure. And NCDs, some of them decreasing, some of them increasing. So having a timeline of Peruvian healthcare, I think, is really important. We spoke about how between 1550 and 1820, the population was pretty much decimated. And then in 1821 to 1970s, it was less of a state of emergency. The population started to level out, and they wanted to address disparity between rich and poor, urban, rural. And in 1960s, NGOs started arriving, and they play a huge role in the healthcare system in Peru today. In the 1980s and 90s, the Peruvian healthcare system all but collapsed because of hyperinflation from tourism and also terrorism. So there was this communist party called Shining Path, which was Sendero Luminoso. It was a militant group, and it attacked civilian populations in order to set up a dictatorship. And they gained support from the poorest in Peru because they were neglected areas by the government, and they said, we'll bring you guys justice. However, these were the people who suffered the most because the Peruvian government, when they couldn't really attack Sendero Luminoso, they attacked civilian populations and people who'd express support for them. And so these people were massacred by the Peruvian military, and the ones who didn't express support for the Sendero Luminoso were put in danger in their rural communities, and they were actually used as foot soldiers by the Peruvian military against the Sendero. So overall, over 70,000 people were killed. Half the victims were killed by Sendero, a third of the victims were killed by the government, and the remaining percent are people who disappeared, which a lot of people in Peru believe actually were killed by the government, and the government is covering it up. So we start to see this really fundamental mistrust of the government, which is going to continue on, even up till now. So the indigenous population really suffered, the rural population, the poor population. And this all kind of culminated into 1996 when there was a forced sterilization program for poor indigenous and rural communities ordered by the Peruvian president, Fujimori. And the idea was to reduce the gap in poverty, things like that, by literally destroying the lower class, which is unethical and horrible, and it didn't work because there's still a huge gap. And NGOs expanded their reach. 2009 to now, so the program ended in 2000. 9 years later, there was an increase in healthcare spending. There are more health services than ever. We are seeing a steady increase in the utilization of healthcare services, including in rural areas, which I think is astounding because it's so recent since the sterilization program. And this, of course, leads to an improvement in outcomes. There's a universal healthcare insurance law, and Peru is working towards universal coverage. However, with more insurance means there's more demand on the healthcare system, and this has led to a bigger private sector, which is kind of the opposite of what the government wanted to achieve. Going more into forced sterilization, because I think the history is just so important. Women were falsely promised free medicine, surgical treatment, food, and transport to the clinic. So a lot of ways that, one of the ways that people try and bring access to rural areas is they bring mobile clinics. You know, they go into the communities and they say, we're here to help you, we'll take you to hospitals. And this is exactly the tactic that was used against people. And specifically, a lot of like Quechua and Aymara groups were coerced into signing papers in Spanish, which they didn't understand. And this is still a huge problem in the Peruvian healthcare system, that they don't really have translators. It's almost entirely in Spanish and maybe in English in the private sector. So indigenous people, they can't consent because they don't understand and they don't have people to interpret for them. And people who wouldn't go and get healthcare were actually denied future healthcare and fined by the government, which just increased poverty. And in 2014, Fujimori was cleared of any crimes against humanity due to lack of recorded proof. And on the side, just some results of post-sterilization, severe economic losses. Women couldn't work for a variety of reasons and maintain their production level, which really, it just increased the gap. And there's no new generations to care for the elderly, and rural communities, as I said, developed a deep mistrust of government health care. So we're going to talk about the Peruvian healthcare system, and I wanted to analyze it through the WHO Health Systems Framework, because I think it's really useful to talk about each specific element of a system. The Peruvian healthcare system is fragmented because of all of these economic and geographical and cultural issues, which limit equal access to healthcare, and it currently ranks number 129 in the WHO's ranking of World Health System in 2000, so it's not that current, but in 2000 that's what it ranked. So it's a mixed system, public-private. We're going to talk about public first. You've got the major players. The Ministry of Health actually takes care of 80% of the public sector healthcare, but it only represents 60% of overall resources. And their ultimate goal is to ensure healthcare for everyone and to lead healthcare policy guidelines. They're also called MINSA. ESSALUD is a social security program, and there's also the military, which is FFAA, and PNP is for police. And so it's employment insurance, essentially. It came after the Peruvian government studied social security systems of Argentina, Chile, and Uruguay to provide protection for the increasing number of union workers and the increasing middle class. The private sector is 10%, we'll go into that later. So what is the issue with this? ESSALUD offers 20% national coverage, and it does actually offer 18% national coverage for the very poorest in the community. But there are high out-of-pocket costs, and it doesn't cover diagnostic services or non-emergency transfers, and it doesn't really work with the Ministry of Health to ensure that coverage doesn't overlap. So we have service overlap, they're not coordinating, and a lot of times you have workers who aren't getting paid enough, so they work in the Ministry of Health, they work in ESSALUD, programs get confused, workers get confused. There's just a lot of redundant services, and it ends up being a waste of money, and it doesn't improve healthcare outcomes, so that's a big issue. There are two types of public primary health facilities. They're run by Serumistas in the rural areas, and Serumistas are doctors who are part of a serum program, which is basically 1-year mandatory service in rural areas. For anyone, you have to do it if you want to work in a public hospital in Peru. But it's 1 year, which is not very long, and people really leave after 1 year, so 2,000 Serumistas are reappointed every year. which makes it hard to deliver healthcare in areas where it's very important that for the community to have good relationships with the doctors, to know who they are, the doctors know their history, things like that. It's hard when there's such a high staff turnover. So you've got health posts. These are located within communities. This is mainly what rural areas have, but there are some in more urban areas too. You've got the technician-run health promotion and prevention services, and you've got physician and ambulatory care for illnesses that don't need diagnostic tests. If you need diagnostic tests, you will get referred to a health center, and this is only located in district capitals, so these can be really far from some people. But there's at least 2 MDs per center. They're better equipped with a lab for basic test kits, and they also have much higher direct and indirect expenses. So there have been complaints of ethical difficulties for doctors where they can refer a patient, which requires them to pay a lot of money they might not have, and they might get a procedure they don't need, or you can keep them at a primary healthcare facility with potentially dangerous consequences. So every time a doctor sees a patient who's ill, and they might not know what they have to decide, okay, can I treat them based on what's common in the area, or do they really need a diagnostic test? So it's difficult. It's an emotional burden on the patients and on the doctor, along with physical burden and fiscal burden. So a lot of patients also, they don't want to be referred. They can't afford to lose days of work. They can't afford travel costs. And again, they don't have confidence in referral care quality, especially indigenous patients who can communicate in health posts that have community representatives, but they know they won't be able to communicate in health centers. So talking about the private sector, oh, I don't know what happens. Sorry. Oh,
Got it?
I don't really know what I did.
It's okay.
So the private sector, more reliable and efficient, shorter waiting times, better staff, and better equipped. All the things we have come to know and love, or at least expect from the private healthcare system.
Wait now.
It's often utilized by expats. They're multilingual, but really they speak English, not Quechua or anything like that. And they're centered in cities. So the private health system is private clinic, private doctor's offices, and also some NGOs. And this was particularly relevant in the 1990s when most of the public hospitals had a cholera epidemic in Peru, and private hospitals were the ones that didn't, and provided really crucial care to people. So in terms of financing, private is out-of-pocket spending and insurance, but less than 3% of people have private insurance. It's almost entirely out-of-pocket spending. You've got NGOs, you've got SLUD, which is takes from your salary to go to insurance, and MINSA, which is the Ministry of Health. So they are paid by taxes, by external loans from other governments, and user fees, so fee for service. Peruvian healthcare is considered one of the worst financed healthcare systems in the world. So this is really not working. Overall, 28.6% of healthcare expenditure is out of pocket, but because people have low incomes, they can't pay high costs, and it's a really non-sustainable system. And what they need is lower prices and higher government expenditure to compensate for it. There are 2 big insurance laws I wanted to point out. In 2002, the Comprehensive Health Insurance, which gives free or low-cost health insurance to the poor and indigenous. And I thought this was interesting that you're required to have it, but it's not automatic enrollment. So part of the money that they made was by finding people who didn't know they're supposed to have it or didn't know how to get it, and would end up paying more, ironically. And then in 2010, they just kind of lowered the minimum benefit requirements. They made better accountability for SIS, and at this point, even only 42.6% of the country was covered by it. Right now, this has, say, between 39 and 43% of the population coverage. SLUD has got maybe 1/3 of the population. This leaves 28% of the population completely uninsured. So again, not good financing system. Continuing on, the total healthcare expenditure, as I said, is 5.5%. So in 2000, there's the Peru 2021 Bicentennial Plan, which allocated 2.7% of government spending towards healthcare. This is actually 56% of the total healthcare expenditure at the moment. Private insurance is 4%, and out-of-pocket spending, again, is 38%, really high. Don't think we have time to go into this, but I wanted to point out the minimum wage versus the cost of average consults and the cost that surgeons make, just to show like surgeons prioritize foreigners because they'll pay more, and private consult can cost really like 3 private consults, 4 private consults can be more than people make in a month. So that's just the important part here. Peruvian healthcare workforce. With the implementation of universal insurance, there's increased demand. And there are more workers than ever, but there are also more workers migrating out than ever. So actually there's been no difference in local worker population densities, even though Peru is producing more workers than ever. And we know there's a direct correlation between workforce presence and increased health. And the highest density of workers is in Lima, which has the best health, and the coast. Doctors are 5 times more likely to choose city work. There is a lack of rural incentives, and specialists work half a month on average. They don't work the whole month, so there's huge waiting lists and huge waiting times. Rural areas we know are significantly understaffed. Here I just have an example of one of the worst areas in Peru in terms of healthcare workforce. They have the 3rd highest maternal mortality. Infant mortality was 3 times as high as in urban areas, and less than 60% of births occurred, less than 40% of births occurred in healthcare establishments, 60% occurred outside of it. And this was just a Ministry of Health intervention to get more healthcare workers to Ayacucho, and actually it worked. It was incredibly successful. And this was in 2000, and they just basically made incentives for doctors to go to rural areas and other workers and to stay there, but also to train local populations. So, you know, people who were born and raised there, who know the community, who care about the community really deeply, and it made a huge difference in the statistics. Okay. So, Peruvian medical products and technology. Much like the rest of the Peruvian healthcare system, the information and technology system is fragmented, it's non-integrated. Individual organizations may record, but if they do, it's usually on paper. So there's a ton of overlap. If a patient goes from one organization to another, they might not have their history with them. It might be really hard to get the papers. It can actually take in rural areas up to a month for critical information to get to another healthcare center, which, you know, can be the difference between life and death. There's a lack of policies on standards and protocols, even for patient registration, data coding, and confidentiality safeguards. And it's because a lot of these information systems, they were built in isolation without an overarching plan, which has led to all of this redundance, to all of this dependence on obsolete technology, and to fragmentation. There's a great need for tech training and competency. The majority of healthcare workers reported really not knowing how to use new systems. And there's no ICT, which is information and communication technologies, for illiterate or non-Spanish speakers, which is at least 13% of the population, more likely more than that. And that's a huge issue. Some universities now are developing some things, and some NGOs are bringing in things. And there's also vertical integration, which is a limitation, in my opinion, because basically this allows insurance companies to own hospitals. And I think it kind of limits medical innovation in some ways because they have less incentives to improve the quality of service because they can save money if they don't. Future plans are looking pretty good though. There has been an exponential growth of cell phones and internet cafes in Peru. So a lot of people are piloting mobile health applications to be more accessible to the population. In 2007, internet use was only maybe 28 out of 100 people. And 60% of users were between 12 and 24 years old. But now there has been a really rapid expansion of access and use. But this means also that there's been an expansion of medical information resources, where healthcare workers have struggled to find qualified medical info in a timely manner. So there is an emerging e-health system to deal with this as well, which is creating scientific journals online that medical healthcare workers in Peru can utilize. But it's very overwhelming. It wasn't really instituted in the best way, but they're working well with it, I think. There is international collaboration. In 2015, the U.S. visited Peru to discuss sharing biotechnology, biomedical equipment, and information systems to help them develop their healthcare system. A lot of things we talked about kind of in Friedman, which with the flattening of worlds, that it's easier sometimes for countries that don't have technology already to pick up new types of technology. And I thought this was really interesting because Peru is picking up on new technology quickly because it isn't held back by old systems. So they are the third country in South and Central America to use Revolution CT topography, which basically, like, if you have a patient who's moving a lot, who can't help them move a lot, it can still